Dr. Friedman and I are sort of a 1-2 punch. So Larry gave you a lot of context about quality and health information technology in America and some comparing and contrasting with Germany. So I'm going to dive a little bit deeper into what we're doing every day here today, which is dealing with COVID. And first I want to say thank you to Pierre for inviting me to join you, and wish that Larry and I could be there in person and Albert, but hopefully we'll make it in December or next year. And also it's beautiful here today. I think many of your guests have visited our hospital, which is pictured behind me here. And it's 70 and sunny, so we look forward to having you back as well. So COVID was first described in December in the New England Journal article. And by March 11th, the World Health Organization had issued a situation report. And by March 13th, the federal government in the United States had issued a emergency proclamation of disaster, which gives a lot of different emergency authority to the federal government. And I would say it was really around March 11th that UC San Diego, which had already had a command center open since February, really kind of went into a deeper mode. And by March 24th, we had actually published a paper about the changes that we had made in our electronic health record and health information technology to help support the COVID crisis. We were the first published paper in the world about electronic health records and how to respond to COVID-19. So I wanted to share some of that with you, as well as some updates. I also want to give credit to our Chief Medical Information Officers, Dr. Millen and Clay, who are listed on here, as well as our infectious disease colleagues, Drs. Toriani, Tablets, and Abeles, who were co-authors. So we had to rapidly build that informatics infrastructure. Obviously, over 95% of health systems in the United States have a deep electronic health record infrastructure. And all phases of care, inpatient, ambulatory, and home, interface with the EHR. And so we saw this opportunity to leverage technology to enhance patient care. A little bit of background, Larry mentioned that we run 2 academic medical centers, or 2 hospitals at our academic medical center, and we leverage the Epic electronic health record, as well as a lot of customization configuration we put around it. And in addition to hosting our 2 hospitals, we also host UC Irvine Health, UC Riverside, another sister UC that has a clinic, our student health services with all 40,000 of our undergraduate and graduate students are on our electronic health record, and over 300 affiliate physicians in 10 medical groups. So we opened our incident command center in early February, partly because San Diego County served as a quarantine site for Chinese expatriates and cruise ship passengers. In fact, Albert, I remember the first plane of expatriates, included a child, and so there was some discussion about whether that family would go to the children's hospital or the adult health system if they needed care. But that really put us in the spotlight sort of early on. And our incident command center, which opened in early February, has a combination of people, as every health system would. But I think something that's really important to highlight here is that our information services department is represented in that command center. And that's important because anytime technologic and EHR related needs were identified in the command center, it got routed really quickly to the right people to help actualize that in our information services department. And so here in just the first 10 days after the federal declaration were a series of tools that we had put in place in our EHR for managing a pandemic. And so at the top, you can see there were screening protocols, system level EHR templates, ordering panels to help standardize the way that we were ordering these and which patients we were ordering them from. Reporting and analytics, which I'll share with you, and I think has really been a game changer. Some communication channels that were new. Some artificial intelligence algorithms, and then finally a lot of telemedicine and patient-facing technology. And in fact, we did this early on, but a week after the federal declaration, our largest government payer, Medicare, came out and said that they would reimburse the same for video visits as they would for in-person visits, and that was a game changer from a financial standpoint. So the travel and screening questions were obviously only pertinent very early in this pandemic, and things changed. But again, putting these workflows in the EHR made sure that every one of our hundreds of outpatient clinics were doing things the same way. We're standardizing the workflow with a standard operating procedure that's very easy to document in a standardized way. The EHR-based template phrases are really important because, boy, early in this pandemic, things were changing on a daily and sometimes hourly basis. And so we built a series of documentation templates that allowed us to standardize that so that even as things changed, the physicians using the same template phrase would get the right guidance based on Center for Disease Control and local county public health decisions. Our order panels, of course, changed rapidly too, as we started with our own in-house testing that was PCR-based, and our capacities rose and our testing guidelines rose. And so you can see the guidance that was in there. Initially it required an ID approval because we only had 50 or 100 tests a day. As our capacity increased, we removed that infectious disease approval requirement. And so again, things were changing rapidly, and we were making sort of hundreds of changes every week in our electronic health record. And then there was analytics, and a lot's been published about the fact that really the most important the most important tool for managing a pandemic is information, right? And so we had a lot of data, but getting it out in a way that helps to support not just information, but knowledge and wisdom was the job of our analytics team. And so credit to them that first weekend of the federal declaration, Saturday, March 14th and Sunday, March 15th, the team was working around the clock. And by that Monday morning, we were getting a dashboard out initially to our executive team and physician leadership, a group about 100. But rapidly, within a couple of weeks, that had opened up to all of our medical staff, all of our administrative leaders, and then ultimately our CEO authorized sending it to our entire employee base. All 14,000 health sciences employees at UC San Diego still get this every single morning in an automated fashion. And there's a lot of important daily readiness information on here. So you can see from March 29th, when we published the paper, that there was 17 patients in house. Of those, we had 9 that were COVID positive on ventilators out of the 31 total on ventilators. And you can see where those patients were, where they're ventilated, et cetera. Since then, we've added another really important section. So this is a trend over time. I think this is actually from yesterday. You see that we still have 30 inpatients in house. We're actually up into a new peak this morning with 33 inpatients. 12 of those were ventilated yesterday, 13 this morning. And of course, the question, everybody asks when they wake up and look at the dashboard is, well, where are those patients coming from? And, what's happened? Is it 13 steady because we've had none going home or admitted, or 13 steady because we're discharging and, admitting a similar number of patients? So this butterfly graph down here shows that information. How many are discharged? Of course, the reds are unfortunately deaths. We've had 14 deaths. And on the admission side, the colors represent where they're coming from. Are they being transferred from outside hospitals? Are they coming from skilled nursing facilities, or are they coming from emergency department or elsewhere? And then our testing on the left-hand side, you see our PCR results around 1 to 2% typically. And of course, we started serology results back in mid-April. And out of our 3,600 serology results, we have about a 1 to 2% positive as well. I put my Twitter handle here because I tweet a lot of these statistics on a daily or every other day basis. And that's been really helpful for the community. In fact, a lot of news has picked up on that. We have dashboards dedicated, of course, just to testing to help us understand how to target and evolve our strategy on testing. And then we have testing, dashboards that are available to smaller groups of folks for epidemiologic purposes with geomapping, for cluster identification, and to help support our epidemiologic colleagues as they do things like contact tracing. Breaks down comorbidities and gender and age groups, et cetera. Not surprisingly, our largest age group getting COVID is in the younger range, under 44. But if you look at our deaths, they're skewed towards geriatrics, just like worldwide. And then all of this data is actually rolling up now across the University of California. So the 5 UC sites representing 4 electronic health record instances, because Irvine and San Diego share the single tenant. We aggregate our data. Dr. Atul Butte, who's our chief data scientist for UC Health, publishes this on Twitter feed, University of California Health every day. Yesterday was actually our highest day of testing ever. Between the 5 UCs, we did, I think, close to 2,000 tests. And this over here shows you the work that's required to aggregate that data because of all the different all the different ways COVID can be ordered in the different UC environments. Of course, we can also now aggregate that geographically, and you see, San Diego in the orange here, you see Los Angeles in the yellow, et cetera. And we can look at our collective volume of inpatients, trends of hospitalizations. You can see here in San Diego, 14 in Hillcrest and 5 in La Jolla that day. We're actually much higher now, up in the 30s. And then I mentioned telehealth. It was clear that weekend after the federal declaration of disaster that things were going to change notably. And one of the things that we predicted was that telehealth demand would go way up. So we actually got that Friday a telesprint team together, a group of leaders from ambulatory operations, from information services, and from our telemedicine team, all in a room. On Saturday, they put together plans. On Sunday, they started calling patients and rescheduling them for video visits, and they held online Zoom tutorials for physicians who had never done telemedicine before to teach them how to do it. And that telesprint command center stuck around for 2 weeks, I think, in person, and then virtualized for a couple more weeks. And the outcome was unbelievable. So you can see right here was the federal declaration. Within 1 week, we had done more video visits in UC San Diego than we had done the previous 3 years. And within 2 weeks, our video visits were exceeding our in-person face-to-face visits, which are represented in blue there. And you can see by mid-April, it was very clear that our video visits were approaching 75% of all visits. And one of the challenges that actually presents is that I believe we're doing too many video visits. The pendulum has swung too far. From a quality and safety standpoint, we've now seen unfortunate incidents where people should have been seen in person. And so you see now a regression as we go back here to closer to 50-50. And that represents in part really a reminder that the medical staff need to see patients in person when appropriate. And we've been working with every service line to make sure that that happens. And of course, the question that comes up is what's the new normal going to be? I think best guess estimates are 20 to 30% of all visits could be done virtually. But that'll be very service and disease dependent. There are some service lines where in-person visits for procedures, tests, and other things are always going to be required. And there's a physical exam may be far less important, and a majority of their care may be virtualized, like pediatric endocrinology or infectious disease. Now, we also, within a week of this crisis, had started talking about electronic PPE, or personal protective equipment. The idea there being, if you have patients who are hospitalized, how do you avoid using up all of your PPE going in and out of the room constantly? And so we had already been planning to turn on a EHR embedded secure chat for nurses. We did that a little bit faster than we anticipated so that the nurse in the room could communicate more easily with medical staff and other members of the care team outside of the room. That was really helpful. In addition, we also rolled out inpatient video visits. And I think I forgot to put the graphic here, but our team put together a custom web portal so that you can dial any inpatient room. We have iPads in every single one of our inpatient beds at UC San Diego, and that enabled inpatient video visits to help preserve PPE and allow virtual visits on the inpatient side as well as ambulatory. Another thing that we started right around the federal disaster declaration was collaborating with one of our radiologists who does a lot of research in artificial intelligence. And we've been talking to him over the last year or so about the possibility of doing clinical research trials. But he came to us right after the federal declaration and said, hey, I've run my machine learning algorithm for pneumonia identification on the chest x-rays released from China of 27,000 patients with COVID. And he's built his algorithm to help identify that in a proactive way. And so we put our clinical research and information technology team together with his team. We took that algorithm out of his server in a laboratory, put it up in Amazon Web Services with some credits from AWS. And we evolved that from a research algorithm to really a production-ready algorithm. And now every single chest X-ray and chest CT scan done at UC San Diego, emergency department, inpatient, or outpatient, is automatically post-processed with this algorithm. The algorithm runs in about 2 minutes. And so what that means is any clinician, radiologist or otherwise, looking at the chest X-ray will also see the AI interpretation of the chest X-ray. And this is done under IRB as part of a clinical research study. I can tell you within the first week, we found several cases where patients who didn't have respiratory symptoms but underwent chest X-rays for various reasons were found to have findings on chest X-ray the radiologist didn't see. And as a result, the emergency department ordered COVID tests that came back positive. And so we don't yet have the rigorous peer-reviewed results on what that sensitivity and specificity is, but it's clearly been helping our clinical care. And in fact, we've got a survey that just shut down that we'll be submitting data for shortly with outcomes on this effort. So I know that we're a little short on time. I wanted to wrap it up and leave some time for questions, but you know, lots of lessons learned here. Usual processes sort of out the window. Our IS department really stepped up in 4 areas: EHR changes, analytics, telehealth, and telesprint support. And then something I haven't talked about today, which is supporting all of the remote work across the organization that was required, you know, as people got sent home for shelter-in-place orders. One of the things that really helped with this was our daily engagement huddles. I'm actually missing ours today, but every single morning, initially 7 days a week, and now 5 days a week, we have these tiered huddles, and that helps support communication quickly up and down the organization. And then what's next? Obviously, a lot of work on data sharing. We're helping lead that in collaboration with state and national partners, finding the appropriate balance of telehealth I mentioned, and then supporting the 3T strategy of testing, tracing, and treatment. Of course, treatment right now is often, you know, isolation and quarantine, but that will change quickly. On the telemedicine side, here's that same graph I showed you for different service lines. So you can see GI, for example, just went home, 100% virtual visits. And that was something we really had to pull back. Surgical oncology, on the other hand, you can see much different. Same with orthopedic surgery and urology, where there was a more appropriate balance. And we're working on some best practices for each service line that we'll publish in the literature as well. On the contact tracing standpoint, just a quick mention, we are in deep conversation with Apple about how we can, you know, leverage the Apple-Google API, and credit to Germany, because I know there was some of your leaders who actually first contacted the companies to say, hey, we need API level access from an OS perspective to make the exposure notification kind of concepts work. On the other hand, I'll say this morning, the Center for Disease Control published a very interesting case study of a church choir and how one single person who went to a church choir infected literally thousands of people, you know, who were contacted by the people in the choir. And I'll tell you that nobody in that church choir was holding their cell phone. And so there are limitations to this technology, and it's really never going to replace the manual contact tracing that has to be done. And I will say that Apple announced a name change. It's no longer called a contact tracing app. It's called exposure notification, and that was partly based on input that we gave them as we've been helping design that. So key points and lessons learned: EHR can be your friend, use it well. I think we reviewed a lot of specific EHR-based tools, and all of this has been enabled by the strong relationships between our clinicians, our IT analysts, and you know, understanding on both sides of what's possible and how to build those tools to meet workflow. So thank you very much for the opportunity to join you and present today, and happy to take questions.